On the last video, we spoke about VQ matching. We talked about trying to optimize ventilation for perfusion, and we said that even in a perfect state, that is about 0.8 throughout the entire lung. Wait, does any of this sound familiar? If not, then go back and watch the video that's linked up here before you go on any further. And while you're at it, if you enjoy these videos, why don't you go ahead and give us a like. And if you want to see more of these videos, then go ahead and smash that subscribe bell so you never miss any more of our crit bits and other videos that were put out. Alright, so if you're back, then you've watched the video and you know what we're talking about. Let's take a look at the lungs. And just as a review, you'll remember that in normal situations, ventilation of the lungs is better when you go from the base to the apices. And the opposite happens when you're looking at perfusion. Perfusion seems to be better as you get closer to the bases. And again, even in normal physiology, this is what leads to that 0.8 that normally happens. But let's take a look at what happens when someone is supine and when they're sick. Let's say like with ARDS. Let's look at what happens then. Now in a perfect world, the alveoli would look just like this. The alveoli and the ventral part of the lung, or the anterior surface, would be the same size as those on the dorsal surface. However, this is not real life. There's something called the shape matching model, which means that because the lungs are conforming to the cylindrical shape of the chest, the alveoli in the ventral portion of the lung are much bigger than those posteriorly that are crowded out and small down here. So they're not the same size. That means they don't participate in the same amount of ventilation. And again, you'll recall that perfusion is better posteriorly, and so this leads to further VQ mismatching. Now you take a person who has ARDS, and what happens is they have a lot of fluid in their lungs. Their lungs are inflamed. There's more inflammatory fluid, and that fluid tends to fall posteriorly, further collapsing these dorsal parts of the lung. It's almost like a wet, soggy sponge where the fluid collapses down. So you have better aeration up top where there's less alveolar units, and where you have more alveolar units, they're collapsed down because of the shape matching and also because of the edema. This leads to significant VQ mismatching and leads to shunt physiology. If there was only a way you could flip things around and make the areas that have more alveoli more aerated, well, that's exactly what prone ventilation does. Prone ventilation takes lungs like this and turns them into this. The previously dorsal alveoli are now better aerated, and there are more of them participating in gas exchange, and this makes that VQ mismatch better. So flipping patients around and utilizing the shape matching model is just one way that prone ventilation can help our patients. Let's look at some more. When we have a patient who's laying supine, we have a heart that's anterior, and although we have lung tissue that's anterior, most of the lung tissue is posterior, and the weight of the heart and the anterior chest is pushing this lung down, and it's making the dorsal parts of the alveoli even smaller. Also, we have the weight of the abdomen that's pushing down on that diaphragm, pushing down on the dorsal and basal segments of that lung. This is going to cause worsened ventilation as well. By proning your patients, we now decrease the pressure on those dorsal surfaces and also decrease that abdominal pressure on these portions of the lungs. And this results in better ventilation of these portions of the lung. And remember that these portions of the lung also get better perfusion, and this leads to better VQ matching for this patient. Hemodynamics can also be improved with prone ventilation. Because there's more aeration of these alveoli, there's better perfusion of these capillary beds to these lungs. That means that there is a decrease in the RV afterload because there's a decrease in the pulmonary artery resistance. And we talked about this before. When you can decrease your RV afterload, you increase the cardiac output from the RV to the LV, and that means better perfusion systemically. The other thing to keep in mind is as these units get better ventilated, there's less hypoxic vasoconstriction happening here, which is also going to decrease the resistance or the afterload on that right ventricle. And then finally, prone positioning allows better filling of that RV, and better filling of that RV means there's more flow over to the left ventricle and better cardiac output. But it doesn't end there. There's even more benefits to doing prone ventilation for your patients. The third way prone ventilation can help your patients is because of gravity. Fluid tends to go from the more dense areas of the lung to the least dense, and this is going to lead to all the wet, soggy lung tissue over here, draining more fluid towards the lymphatics and allow better drainage and better clearance from the lungs. There's also some evidence that patients who are pronated have better mucociliary clearance of their lungs and allows them to clear out those secretions for better recovery of their lung tissue later on. So just to review, we have better VQ matching by prone ventilation, we have better hemodynamics with prone ventilation, and we have better fluid and secretion clearance with prone ventilation. And you might be asking yourself, what's the evidence for this, Haney? You might also be asking yourself, why haven't you changed your pen yet? Well, both of those things are about to be fixed right now. Now I'll link this paper in the show notes, but just know in 2013, New England Journal of Medicine, there was the PROSEVA trial. This was the first trial to show prone ventilation could be helpful for patients with ARDS. Patients were enrolled who had a PF ratio of less than 150 with an FiO2 greater than 60% and a PEEP greater than 5. By the way, there were 466 patients in this trial. What they found was the prone group had a 51% relative reduction in mortality or a 70% absolute reduction in mortality when compared to the supine group. The number needed to treat is 6. And you might be saying, why aren't we proning all our patients? And that's a fair question to ask. Proning patients is not without its risks. We can have dislodgement of tubes. We can have dislodgement of lines. We can get nerve injuries. We can get pressure sores. And proning requires a highly sophisticated team approach. Now, this isn't to say that this can't be done, but if you're going to do it in your unit, you're going to have to teach people how to do it in a very coordinated and safe way because these things can happen. Now, you might be asking, how long do you keep your patient proned? In this study, they kept their patient prone for at least 16 hours, and there are studies that keep people proned for even longer. That might be a talk for a different day, but just know when you're proning your patients, they're going to be in it for the long haul, at least 16 hours a day, and then you're going to put them back to the supine position for 8 hours. Despite these limitations, this is something very important to know because in our COVID era of managing patients, prone ventilation is making a difference. And I suspect when we have data, that's what it's going to show. All right, we talked about a lot of stuff on the script bits, so you may have to go back and watch it again. If you need to brush up on that VQ matching, go back to the last video, Crit Bits number 6, and watch that again. Don't forget to give us a like if you enjoyed this video, and hit that subscribe bell if you want to see more of our videos. Thanks for watching.